Hans.
Good morning, my lady. Before Mark Tilley commences his evidence this morning, it may be helpful for me to provide you with an update on the timetable for the hearing today and tomorrow. As you know, Dr. Stuart Edwardson was due to give evidence this afternoon. Having carefully considered the helpful evidence that Dr. Edwardson has provided in his statement and reflected on the evidence already heard last week about the impact of the pandemic on intensive care units, patients and those working in ICU, the inquiry has concluded that it is not necessary to hear oral evidence from Dr. Edwardson today. A number of witnesses this week will also be giving evidence about critical care in the pandemic. My lady, with your consent, the inquiry will publish on its website Dr. Edwardson's statement after the hearing today, and I hope the public will be reassured that you will take his evidence into account when preparing your report and making recommendations. As a result of Dr. Edwardson no longer giving evidence, Professor Catherine Rowan will commence her evidence this afternoon and will return tomorrow morning. This will then be followed by the evidence of the intensive care experts, who will commence giving evidence slightly earlier than initially scheduled.
Thank you very much, and I shall of course take into account the written evidence helpfully provided. Some people sometimes forget that this isn't just about oral evidence, the inquiry is about written and oral evidence together. Thank you very much.
I'm grateful. May I please call Mr. Mark Tilley?
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Thank you very much for coming along to help, Mr. Tilley. If at any stage you feel slightly distressed by what you have to tell us, please, I'll take a break if you need me to, but sometimes I find that just having a breather and a sip of water helps people when they're distressed, and it's better to get it over with. But I'll be in your hands. You tell me what you need to do.
Thank you, my lady.
Good morning, Mr. Tilley. You should have your witness statement in front of you, and that is INQ 304859888.
I do.
Thank you. Mr. Tilley, it's right, isn't it, that you are an ambulance technician who's been working in the NHS ambulance service for over 20 years?
That is correct, yes.
And you've described in your statement how you've responded to all types of calls, from emergency life-threatening incidents to non-emergency transport incidents as well.
Well, yes, that's correct.
And it's also right, isn't it, that you are a GMB representative?
I am.
And that's a role that you held before the pandemic?
Yes.
And throughout as well?
That is correct, yeah.
Can you briefly describe your role and responsibilities as a GMB representative during the pandemic?
So during the pandemic, we were asked and we were there to look after the health and safety well-being of our members, our colleagues. It was the governance processes behind the scenes for making sure that everything was as safe as possible.
And on a daily basis, what did that involve?
So there was, for me, there was multiple meetings. We were having 4-hourly meetings on some occasions when it was really at the height. There was the planning of what PPE we had or didn't have. There was the vehicles and what equipment they carried, what was wrong with them.
And we're going to touch on some more examples as we go through this morning. In terms of your role as an ambulance technician, you were, before the pandemic, mostly working in a behind-the-scenes role. Is that right?
Yeah, that's correct. I was a GMB rep, and I had full-time release to be able to attend meetings, policies, disciplinaries, grievances, sickness absence meetings, and planning of what was going on forward. I undertook a certain amount of road shifts to keep up my clinical skills, because ultimately that's what we are there for.
And then when the pandemic hit, you moved back into a patient-facing role on the front line.
Yeah, I picked up extra shifts on the front line. I didn't have to, I wasn't made to, but that's where we are a collective, we are a group of people, we are there for our patients. Staff were falling off sick, staff weren't able to attend work because of health problems, therefore others had to backfill. And I was one of the first to volunteer because it was the right thing to do.
And you've described how the pandemic had a profound impact on your work. Can you give us a few examples of how that frontline role was different during the pandemic to before?
So before the pandemic, we all know that the winter pressures were hard. We know that there was delays. However, that escalated tenfold with the amount of calls we were going to, what we was expected to undertake prior to getting to the patient. We were having to put our Tyvek suits on if we were going to perform patient aerosol generated tasks, i.e. CPR, when we were bouncing up and down on someone's chest to protect ourselves and others, and that took extra time in getting to that patient.
And would you know, you describe it taking time before you got to the patient, so would you know before you arrived at the incident as to whether you would need to don that level of PPE? Sometimes
we would know because it was a confirmed cardiac arrest, other times we wouldn't, but what we did know is that basically everyone was having breathing difficulties of some description, and sometimes that could be that the breathing problems are because there's a low respiratory rate, that they're not actually moving sufficient air to get the right amount of oxygen into their body.
And if you didn't know in advance, so you would be donning when you got to the scene, can you just explain to us step by step what that process involves and how long it might take you?
So actually we had to don when we got to the scene anyway. We had lots of conversations. Our Director of Nursing and Quality and Director of Operations at the time, I recall having many meetings with them saying, why can't one of the crews on the DCA, on the double crewed ambulance, be in the back of the ambulance with the suit on already, and therefore the driver being in the front, that would be acceptable. We work on an SRV, which is a single response vehicle. We might work on a DCA double crewed ambulance, single crewed because someone's gone sick. So having someone in the back of the ambulance would have actually meant that we were actually able to get to the patient's side quicker. Might have only been a minute and a half quicker because of putting that suit on, because if you've already got it on, you are ready to go. We didn't have that, and that was deemed as inappropriate because and for me, the excuse that was used was the attendant should be using the MGT screen, which is the computer we got in the front of the ambulance, to read what was coming through, and the airways radios, they were there to answer that, all of which that they could have done either over the back, in the back of the ambulance over the airways radio, and the computer we could have turned off part of it, so we could have actually been at the patient's side a minute and a half quicker in those really most serious cases.
And coming back to when you do arrive and what that process involves, can you just briefly describe that for us?
What we ended up doing was pulling up at the scene of the address, and we would get out of the vehicle, and we would have to get into the back of the ambulance to put on the Tyvek suits if that's what we were going to be doing, and that meant taking off our boots because the Tyvek suits most of the time wouldn't go over them, which took extra time. So in the back of the ambulance, you would have seen the ambulance rocking where we were taking off our outer jacket, perhaps if we had that on because it was a cold day, putting on the Tyvek suits, and then collecting the bags that we were going to take into the patient's house. And all of that could have taken a good couple of minutes, 3 minutes or so, before we got to the patient's side, even if it was outside. There was times where we didn't need to have the Tyvek suits on, but we would have to put the aprons on. Aprons are fine if you are in a room, if you're working in a hospital setting, there's like in here today, there's no breeze, but when you're outside, all that's happening is the apron's blowing up into your face, onto your hair. They were poor quality. When we went to some really good, thick aprons, they didn't have long ties on them, so you couldn't tie them up. It just wasn't suitable. And then you've got your arms exposed anyway, which is fine because you can wash them. But if you've got a jacket on because it's cold outside, you couldn't then decontaminate that the following day. You couldn't wash it between shifts because you only had one.
There's 2 points I want to take from that. The first, I think, is in relation to the aprons and the suits that you mentioned. I think you've said in your statement that there were some occasions where there weren't enough aprons or suits, and you had to consider alternatives. Could you just explain what alternatives were considered?
So there was. We had what's called a standard load list, which is the equipment that should be on the ambulance.
Sorry, standard?
Standard load list. It's an equipment list, basically, for the ambulances. And on that, there was 3 extra large suits, 3 medium suits, and 3 large suits. Bearing in mind, we're probably doing, unless we were stuck at hospital, we were probably doing 6 jobs a day, and there's 2 of you, but there's 6 in total, various size suits. Sorry, can you repeat the question?
Yes, of course. You said at times that there wasn't always enough, and you had to consider alternatives.
Yeah, so therefore there wasn't enough for us for the whole shift because there wasn't the availability. The aprons were in short supply. We couldn't get appropriate equipment, appropriate aprons. So we seriously considered using bin bags. And literally cutting a hole in them because that way they wouldn't blow up in front of your face, and it was a barrier between your clothes and the patient. Bin bags wouldn't have been the most sort of like sensible, but it was obviously hard times. The alternative would have been that the trust provided extra uniform. Because we could have technically got changed between patients if we needed to. But obviously that would have meant ambulances were not responding every time they'd finished with another patient.
And then the other point you mentioned is regarding the jacket that you were wearing. Could you describe what when you would be required to wear that and what that was like?
So we all know the NHS is 24/7. For the ambulance service, it's 24/7, wet, dry, hot, cold, and also the environment you're in. Because personally, if I'm going into a woods to go and get a patient out and it's a hot day and it's lots of undergrowth and that sort of side of things, I would be putting my jacket on because it protects my arms. But if it's cold outside, if it's night time, you've got your jacket on to keep warm. The only thing we could do is perhaps try and clean out, wipe down the arms of your jacket afterwards, because you didn't have the time to wash your jacket between one shift and another.
And would that therefore be over multiple days?
Multiple days, and with the specification of the vehicles, technically what you should have been doing is hanging your jacket up on a clip that's right behind your head. So if I was a driver, it'd be there. If I was the attendant, it would be there. So it'd be hanging down right behind me in what should be a non-clinical environment because it's the front of the ambulance, but it's got equipment or exposure to bodily fluids on it right behind my head.
And then coming back to when you were putting on the PPE or the RP when you arrive at the scene, what mask would you be wearing?
So most of the time, and obviously through the different waves and the information that was out there, it did change, but most of the time it was the FFP2, just the sort of like very cheap elastic band around the hoods, around the ear loops. You would be wearing that in the actual ambulance to the scene.
Did you mean FFP2?
The surgically fluid repellent masks.
The
I think it's FRSM.
Yeah.
Different
Yes.
terminology. I do apologise.
It's just that the FFP2 is a version apparently that we don't use much in the UK, but it's used a lot in Europe, and is an alternative to the FFP3.
So I'll be led by you, milady.
I'm learning a lot about masks.
Yes, the blue one.
Yeah, the blue one, the one that you would see when you went into a hospital or whatever, we would wear them most of the time around our buildings and in the ambulances. So we would have that on for most patients, but upgrade if we were performing certain tasks with the patients, or if we had a concern, or eventually we got given the actual hoods, which have got respirator masks, battery-powered packs.
Can you recall when you received the hoods?
I would have to check that up. It was fairly early on. I recall conversations about the fact that we'd got the last batch of them because they were no longer being produced, and it was a tie-over situation with what was able to be sourced.
Okay. Moving on to some of your work in January 2021, which you've described in your statement. Can you provide some more information about how your work changed during that period and what it was that you were doing?
So obviously we all know there was waves. It was hitting different areas at different quantities, amounts, and that was changing daily, weekly. Living and working out of the Bognor Regis, Chichester, West Sussex area, it was quite quiet in the sense of what was going on nationally. When we were having EU exit, because obviously I work for South East Coast Ambulance and Dover's there was a lot of concern and work that had been done for the road network, because there was concerns it was just going to break down and no one would be able to move. So there was about 40 of us that had volunteered to go up to it was a hotel up in Sittingbourne and work out of there for at least 3 weeks. It was the plan, to depend on what was actually happening. It was like a different world up there. We had ambulances that were brought in for us. Most of them were the most run down because the local areas didn't want them, so that's what they'd provided. But it was an ambulance. We begged, borrowed and stilled, but then that was happening generally anyway. The patients were as poorly as elsewhere, but probably for what we'd been experiencing and seeing down in Sussex was a greater requirement of care. Going to the hospital, I recall one day going to hospital about an hour and a half after my shift had started. So I've already got to my first patient, and we've ash-iced the patient to hospital. So they're a poorly patient, we've pre-alerted them. We turn up at Medway Maritime and we park in a queue of ambulances. So I think we were doing 10-hour shifts on that road to up there at the time. So it was 6 o'clock start, for example. So we were there sort of like by 8 o'clock. Well, when our shift had finished, we were still there with the patient in the back of the ambulance. We'd run out of oxygen, so we'd had to scan the hospital to try and find oxygen. The consultant or a doctor had been out to take bloods. Our patient had deteriorated quite heavily. It was a snowy, cold, icy day. We ordered pizza to the registration of the vehicle so that we actually had something to eat that day, because otherwise we wouldn't have had anything to eat. Trying to source a cup of tea. And I know it's not about us as the clinician, but we couldn't be in the back of the ambulance with the patient because of the exposure, because we had to be just slightly outside the back watching into them. And the patient trying to look after their bodily functions, their well-being, as well as how poorly they were out there for hours. That was different.
And the experiences you've described there around the equipment available to you in the ambulance, Was that an issue that you experienced again? Did you have any other experiences of that?
So because what the organisation had done, they'd opened up an ambulance station that had been closed down. Obviously, everything had been stripped from it. So we then had to try and make it literally within a few weeks a proper functioning ambulance station. There wasn't the supplies coming through of masks or hand gel, sort of like specialist little bits of equipment that we might use on occasions. We're out and about in the ambulance for the whole 10, 12 hours of our shift. You never know what you're going to be sent to next. So you need to have all of the equipment there, because otherwise you can't do the best for the patient. So we were always trying to find, there was blankets, access to blankets was really tight on occasions because it wasn't getting through the laundry system quick enough.
And I think in your statement you've described some of the problems with ventilation in ambulances, which you've just alluded to. Can you explain what those problems were, in particular in the summer and in the winter months?
Yeah, so over the years we'd highlighted that the ambulance was our work environment. If it's really hot outside, it's hot in the ambulance and the air conditioning doesn't work, it's uncomfortable. Certainly I grew up with my mum and dad and they didn't have air conditioning in the car, you open the window. However, we are in a medical environment and air conditioning can help reduce the temperature in the back of the ambulance. So we've got a sepsis patient on board, we don't want it to be really hot in there, we want to be able to start chilling it down. We didn't know whether the recirculation, the systems within the vehicles were separate in the front of the ambulance to the rear. So whether the particles, because obviously it was airborne, was just recirculating around, we still don't know as to the different vehicles, because there are so many different types of ambulances and manufacturers, as to whether the air goes taken from the back and from the front to the back. We don't know whether it filters it properly, but what we do know is that some of the vehicles had errors and faults with them where you couldn't put heating on in the front because, like, I'm not a mechanic, but the valve isn't, or the pipe's not connected properly because it's done 300,000, 400,000 miles, it's bounced off or it's not been connected. And therefore the heat's not there, but without putting the recirculation on, you can't have the heat. And of course the recirculation is what we didn't necessarily want unless there was a proper particle filter on it.
And did you receive any guidance locally or nationally about how to manage these issues?
So there was conversations, there was some communication, but if I may touch on the fact of communication, although believed to be quite good, that communication that was sent out, the staff were going into work, picking up their ambulance and basically going straight out to patients. There was no time built in for what in hospitals they class as huddles. In the ambulance sector, certainly for our organisation, there's not the time or the built-in facility to do a huddle, so you wouldn't have any important information actually directly told to you. It's only if you'd picked it up on an email, and with 40, 50 emails coming in, days off and then coming back to them without a sign being put up that you might have seen, you wouldn't have known that communication coming out. And there's no, communication is good, but actually it's about the understanding of what it's meant to be saying, and that wasn't and never verified by anybody. And
just finishing up on your time down in Kent, in your statement, you've alluded to just a moment ago, you've explained that you were staying in a hotel away from home down there. Can you explain the impact that had during that period of time? So
we travelled over, some people travelled over New Year's Eve. I travelled over morning of New Year's Day. So we'd said goodbye to our families. We knew that was going to be for about 3 weeks. We were told we could go back home on our 2 days in a row, day off. But that obviously puts extra pressure on the fact of you're going home to your family and you've been in some of the worst sort of areas of dealing with patients. you're in a hotel room. Many of us will have stayed in a Premier or a Holiday Inn in our time. That was what you were in, so you couldn't go and socialise because that was stopped at that particular point in time. So you were at work in an ambulance with your crewmate for 10 hours, 12 hours. Then you'd go back to the hotel, and that's where you would sit, sleep, and you had nowhere to go. So it was the facilities that was there, the television, and a phone. You hadn't just to mull over what you had been seeing, the queues at the hospital, the poor patients that we were going to. I went over there thinking I was going to help multiple people. I probably did, but it didn't feel like it. And afterwards, you come away thinking, was that real? Did I really do that? Did I spend all that time in the hotel room, all that time sitting outside the hospital, and actually only see a few patients, poorly patients? Yeah, I'm sorry.
It's okay. Was there any support provided to you at the time or after that period of time?
So in the ambulance service, we use a thing called TRIM. I can't remember what that acronym's for, I do apologise. But that's 72 hours or so after an event. So it's fine if you've been to an individual incident that may have triggered some feelings, some concerns, but this obviously was over a long length of time. Me, because of my union role, I knew where I could go to talk to people, but I'm not aware of any communication from the trust to the 40 people in this situation that went up there, let alone the rest of the staff, as to, do you want to talk after the event? I don't think that's ever been sent out.
Continuing then on the topic of infection prevention control on the ambulance vehicle itself, and access to PPE. In your statement at paragraph 11, you've summarised a number of issues that you experienced during the pandemic with those. And I wonder if you could perhaps just describe some of the other issues that you had.
So, yeah, under the topic of IPC, we should have got a, if you like, made-ready ambulance. A lot of the time they were being hot loaded, so it's just bags being replaced with the equipment. Obviously, fluids or spillages would have been wiped up, and maybe a quick mop over. When we got a patient to hospital, because service level agreements have changed over the years, there's no mop and bucket at the hospital for us to wipe out the floor of the ambulance. We would have wiped down with Clinell wipes the stretchers and that side of things. But the masks when you took over the ambulance were generally the ones in the front of the ambulance was in the fridge. We got cool boxes in the front of our ambulances. So if you're storing something like that in a fridge, actually, how good is it actually going to be? Because of course it's going to be damp. So is it going to work? Is it suitable? The dates on the gloves, on the masks were all expired. We had concerns as to how they'd been stored, because we know that the government had obviously contracts with different individuals to store them in warehouses, and we know that some of those were damp and leaky. At least that's what I've been told. So the aprons not being suitable, the gloves being out of date, and a lot of times because we were getting some really cheap, nasty gloves through, you were putting your hand straight through them to start with. They ripped and tore quite easy. The masks being stored in the fridge. If it was the more solid surgical, more fluid, FFP3 yeah, masks, they were stored in Chinese containers. We literally got some Chinese containers, or the organisation did, and that's where they stored them. Now, if you go for a small size or a medium-sized Chinese and you put something that's going to go over your face, it's not going to fit in there, so it's squashed down. And then we put that into a bag and we again squashed it again to get in. So actually, have we stored it correctly? And that's what we were being expected to use and trust our lives with. And obviously then going home to our loved ones, knowing that 24 hours, 36 hours later, we might have symptoms because the equipment, the PPE, hadn't been stored properly and wasn't in date. Is that?
Yes, thank you. Had you had any fit testing for those masks?
So previously, no. This was all had to be worked up very quickly. Fit testing was done. There was a process that was taught to someone, that was taught to someone else, that was taught to someone else, and they would sort of like try and fit test you. You had to guess whether there was a sweet smell or a bitter smell that was done to see whether you'd passed or failed it. I actually failed it with, I have lost a little bit of weight, but I failed it, so I couldn't be fit tested on the masks that we had. Bearing in mind there was 3 or 4 different styles of masks and you had to be individually tested on each one. And until we started sourcing the hoods, there was no way of actually being properly protected.
So during that period where you'd failed the fit test and before the hoods were introduced, what were you wearing?
Before that, well, before COVID, nothing. And since the start of COVID, we were at times wearing the masks. Information changed. We weren't wearing them in crew rooms or EOCs. We weren't, obviously, that wasn't the recommendations at the time. And in the ambulance, you were there, you knew that you were at work, you felt fine. Why would you have it on? Until obviously knowledge changed and information was shared to wear the masks in the ambulances.
And did you receive any training or advice about how to communicate with patients, or, for example, when you were wearing the PPE? And did that cause any problems? Not
that I can recall. Because of the condition of my mother-in-law, I normally get told I speak too loud when I'm talking to her, but she obviously watches our lips moving and she can talk to us in her way, and that taught me over the years that just to slow down and take my time. With wearing a mask, dementia patients, hard of hearing patients and others can't get that mouth movement from you. So when the hoods became available, I actually went over to wearing my hoods for virtually all the patients, which scared some people because they were thinking I'd bring into hospital really, really poorly patients when it was, I don't know, painful ankle or whatever that they might have fractured. But of course I had my hood on. But the patients could see my face, they could see expression. Wasn't taught that. That was life experience that I'd done that because of. And even today, still don't think there's been any learning from any of this or that topic, because there are occasions where we should still be wearing face masks and today.
Moving on to some of the non-clinical areas that you would have been in during the pandemic. So in terms of ambulance staff rooms and offices, were there any issues with social distancing or IPC measures in those environments?
So it was very varied. We'd highlighted about space over the time, but obviously it's all about budgets. The desk that I'm at the moment would have been in some locations a large desk for us. So if you take this as being a large desk for us to have a meal at, there was a white line drawn down the centre of it. One would be one end, one would be the other, and that's where we'd be expecting to have a romantic meal and eat our dinner. There was no social distance in some areas because it wasn't physically able to be done. It depends on how far you want to take safety. If we turned up somewhere and the knives and forks, the plates were still dirty from the last people that used them, we've obviously got to wash them up. But in the in bigger areas where let's use an EOC as an example, where they've got
just to stop you there. An EOC, do you mind?
Emergency Operations Centre, so the control room. They've got dishwashers, but they went over to using disposable plates and cups. But when we were on the response post where the table was this size, we would have reusable stuff, which was nice for the environment sort of side of things. But it's about where do you level that risk factor. With in rooms, functions like human resourcing, organisational development, finance, they just squirreled themselves away at home very quickly and went over to using Teams for everything. So that freed up a bit of space. But we couldn't. We had to go through a process, and I'm sure other organisations within the ambulance sector elsewhere would have done to spread out the desks that the people were at to take the 999 calls, because they were a desk similar to this with 2 or 3 screens on it, and there were literally just banks of them because it's a call centre. It's gone over to the call centre environment mentality of how much can we squeeze into this space to get best value for money. So everyone on top of themselves.
And did you experience or hear of any experiences that drivers in non-emergency patient transport vehicles had with IPC guidance? So
in many areas, obviously, the patient transport services have been subcontracted out. In some areas, they're still in the NHS. Majority of those vehicles would be van conversions with no bulkhead. So it's like the cab and the rear of the vehicle are all in one. So not the issue to a certain extent about the circulations we had in the double crewed ambulances. It's just literally because then you've got one person that's driving, goes and picks up a few walking wounded people that are pre-planned into hospital. It was, sorry, what was the question?
Were you aware of any issues with IPC measures in those vehicles?
Yeah, so it was because it was exposed. The driver was in the rear with all their patients getting on and off, and it was just that one person. So there was no separation. As to the equipment, the IPC side of masks would have been similar in the NHS setting, I'm sure. We had some patient transport vehicles which, because of trying to segregate, the service purchased bulkheads that was then put into the vehicles over a period of time, but all too late in the day.
And in terms of the information that was available to you during the pandemic, were you assisted at all by your GMB role? And was the information accessible to you throughout?
So I was lucky, unlucky, depending on which way you look at it. I was aware of what was going on, obviously, behind the scenes. The plans about using ice rinks to store bodies, the fact of what the figures were, where the concerns were coming from, the lack of equipment. I had the ability to challenge for myself or for my colleagues the fact that we were doing things that was probably just fundamentally wrong by expecting them just to follow and not ask questions.
And it's a difficult question, but can you describe for us, or anything else you want to add, as to the long-term impact that the experience of the pandemic has had on you working on the front line and those around you?
So my family was... I could have stayed at home and worked from home to look after my members, to look after the patients from there, because obviously some people need to be working from a non-patient side of things to have all of the cogs working in the engine, so to speak. I exposed them to elements of risk that I could have avoided, and that's something that I live with. But I would be going home from work and having to strip off in the hallway so that I didn't go in my uniform to try and protect them. That plays on my mind. Turning up at people's houses where someone was unfortunately dead inside the front window or just in the on the pathway up to their property. And I've got out of the vehicle and I would have normally gone over, start bouncing up and down in the chest. But we went and got our masks and suits on and all of that. That plays on my mind all the time. Would I do it again? Yes. I'd be jumping out there straight away to go and start supporting my colleagues on the front line and responding to patients if we were to get another wave of something. Do I hope that people would question more? Yes. I bottle things away. I'm told quite a lot of times I'm cold. I'm not. I just deal with it in the way that I deal with it. So I think I've answered part of your question, but not all of it. So do you want to rephrase?
Okay. It was, if there's anything else you wanted to add about the impact on you and those around you, but if that's everything, that's
So for me, we can't change history. No matter what you talk about, it's history. We can't change it. It is what it is. But what we can do is learn from it. We can adjust it. We can make sure it doesn't repeat again, or that we've at least looked at everything and made an informed decision. But all we're seeing at the moment is things have reverted back to what it was before, and tight spaces for working, still having out-of-date equipment, consumables on stations and getting into the system, vehicles that are not fit for purpose. We're lucky, I suppose, in a way, down south. We've got quite a lot of make-ready centres, but the concept of make-ready centre was to be all-encompassing, which would mean like laundering the uniform rather than taking it home and using your own washing machine to wash the bodily fluids. And then obviously your family's undergarments going in it the following wash. All those sort of bits are what I just hope that we learn from. And it's understanding that it's budgets, but actually it's what does the public want? What does the patient need? What does the staff member that's attending the scene need to actually do their job properly?
Thank you, Mr. Tilley. I don't have any further questions, my lady.
I don't think there are any other questions
No,
to
there
come. Thank you very much for your help, Mr. Tilley. I'm very grateful, and I understand how difficult it must have been for you and your colleagues.
Thank you, my lady.
Thank you very much.
Yes.
My lady, I think we will move straight to the next witness. Yeah. My lady, may I call Mr. Marsh?
I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Mr. Marsh, I think you are first witness in full uniform.
Thank you, my lady. Good morning.
Good morning, Mr. Marsh. You should have your witness statement in front of you, and that is INQ 30479-041. Mr. Marsh, you're here today in your capacity as former chair of the Ambulance Association of Chief Executives, a role you held from 2014 to July 2020. Is that right?
That's correct.
And also as the current National Strategic Advisor for Ambulance Services at NHS England, a position you've held since 2018.
That's also correct.
And you are also the current Chief Executive of West Midlands Ambulance Service.
Yes, that's correct.
I want to start with the centralisation of ambulance services in England at the start of the pandemic. And it's correct, isn't it, that ambulance services in England were led under a single command and control structure that was supported by the National Ambulance Coordination Centre, or the NACC, from around 25th of March 2020.
That's correct.
And in your statement, you've set out the role of the NACCC, but can you briefly summarise that for us, please?
In the initial stages of the pandemic, the National Ambulance Coordination Centre was essentially collecting intelligence, situational awareness from ambulance services across England to establish the pressures that were being exerted from the pandemic. So collecting information, updating the live NAC dashboard, and also collecting information from ambulance services that were then fed into national directors at NHS England.
And from around September 2020, when the national emergency level was lowered, it's right that the NAC responsibilities changed, didn't they? Could you just briefly say how they changed?
That's correct. There were two aspects of the responsibilities of the National Ambulance Coordination Centre, and indeed my role, that were moved from the national coordination to the regions, which were requests for military assistance to civil communities, so military support, and secondly, mutual aid as well was moved to the regions.
Do you want to briefly describe your role in NAC?
My role in NAC was to support the preparations for ambulance services in response to the pandemic, to provide advice to ambulance services on what I thought they should be doing to prepare and then to deal with the various waves of the pandemic, to oversee and make recommendations on the escalation of Protocol 36, the flu, the pandemic protocol within the triage systems, the deployment of the mutual aid of the St John Ambulance National Contingency as well fell within my responsibilities, and also working with British Telecom when we put in place the two filter arrangements, one for dealing with information calls and secondly for dealing with 999 duplicate calls as well.
And we're going to come on to discuss some of those this morning. Did the emergency level increase again after September 2020? And if so, was the decision to change the responsibilities of NAC reviewed again?
The level did change. So you're right that the national emergency within the NHS was de-escalated to a 3, was increased again to a 4. The levels of responsibility, i.e. the MACA requests and the mutual aid, remained with the regions at that time. They didn't revert back to national coordination.
How many levels are there?
4, my lady.
So 4 is the worst.
Yes, my lady.
And it's correct that you didn't have any involvement as the strategic advisor, this is, with your equivalents in Wales, Scotland or Northern Ireland, did you?
That's correct.
And you've also said in your statement that you didn't have any relationship in that role with the College of Paramedics, the Chief Medical Officers or public health bodies.
That's also correct.
Touching then on your role in the AACE, the Ambulance Association, that's a membership organisation for ambulance trusts across the UK, isn't it?
Correct.
And all 10 English ambulance services and the Welsh Ambulance Service are full members, is that right?
Correct.
And Scotland, Northern Ireland and the Isle of Wight are associate members.
Correct.
Could you just very briefly explain what the distinction is in practice?
There's really only one distinction, and that is that full members, i.e. the 10 English ambulance services and the Welsh Ambulance Service, are able to vote, and the associate members are not. But in terms of voting, the only time I can ever recall us voting is to elect the chair of the association once every 3 years.
And again, as chair of AACE, you didn't work directly with any equivalents in the devolved nations, did you?
That's correct.
Or in that role as chair with the College of Paramedics?
That's correct.
And the AACE was represented on the UK IPC cell, but not by yourself, is that right?
That's also correct.
And we'll come on to discuss that more in due course. Turning now to the topic of capacity in the ambulance service. You refer in your statement to REAP levels, REAP. Can you briefly explain the 4 levels and what the agreed national triggers were for those levels?
So essentially, an ambulance service operating business as usual, where activity is stable, staff attendance is stable, then that ambulance service would be operating at level 1. As pressures emerge, which could be in response to increased emergency activity or inclement weather or staffing, those escalation levels will increase up to the highest level, the fourth level. And at each level, not only is there a series of triggers that determine the escalation of each of those levels, there's also a set of actions that should be considered by each individual ambulance service to determine their response to mitigate those pressures that are being presented.
And were there changes to the trigger levels during the pandemic?
There weren't changes to the trigger levels. The trigger levels are already established within the policy and within the procedure.
And it's correct that you advised on when the timing of escalation and de-escalation of REAP levels and therefore the impact on the triage systems during the pandemic, didn't you?
Not quite, if I've understood the question correctly, if I may.
Yes.
So the levels of REAP is a matter for individual ambulance services. They determine the level that they believe is appropriate, dependent upon the prevailing circumstances and the actions that they're able to take. Where I was recommending escalation is in relation to the Protocol 36 of the 999 call handling triage system.
Which we'll come to. Thank you for clarifying. So at the end of March 2020 in England, it's correct that 6 out of 10 ambulance trusts were at REAP level 3 and 3 trusts were at level 4, which was extreme pressure, weren't they?
That's correct.
And that level 4 of extreme pressure also includes the potential for service failure, is that right?
Potentially.
And then moving forward into July 2021, is it right that all English ambulance services were at REAP level 4?
That's correct.
And that continued into the end of 2021, around November?
Yes.
It's correct that you advised on increasing capacity in your role as advisor to NHS England and as the chair of the NHS England 999 ambulance cell, is that right?
Correct.
And you've described some of the objectives of that NHSE cell and the topics discussed in your statement, which included triage systems, protocol levels, and to review data. Is that right?
Correct.
You've said in your statement that around 26th of March, you advised that 999 call handlers' capacity should be increased,
yes,
and that trusts should look to using students to help with that capacity.
Yes, but just to clarify, if I may, please, earlier on, as pressures were building in response to the pandemic, I'd already advised ambulance services that they should be acting now to increase capacity both in the control room and in ambulance crews. So that was happening throughout February and into March. In relation to the point about the deployment of university students, my initial advice was that commensurate with their training, given they're in three years, so year 1, year 2, year 3 students, those students should be mobilised and deployed where possible to help support and increase ambulance crews, not necessarily in the control room, but that clearly is a consideration that could be made on an individual basis.
And I think you've said in your statement that not all trusts followed that advice, and we also heard from Ms Nichols of the College of Paramedics last week that perhaps students could have been used more effectively in increasing capacity. So what's your view as to what the barriers were to increasing capacity and how perhaps that could be improved going forward?
So certainly the mobilisation of university students onto the front line has never been put in place previously. My view was that we were confronted with a national emergency, and what I had seen happening in parts of Europe and some states in America where emergency services were under enormous pressure, I was absolutely trying to ensure that the ambulance service across England did everything we could as early as possible to increase the number of ambulance crews. And so therefore deploying those students was something that I saw as a really valuable resource, given it was a career that they had chosen to pursue, which is why they'd gone to university, and that potentially, particularly the year 3s, had already spent nearly 3 years at university, a significant proportion of that time as part of their clinical placements with the ambulance crews. And therefore, to me, it just seemed a very obvious way of mobilising those onto the front line to support our existing staff by splitting crews, and therefore potentially being able to increase quite significantly the number of ambulance crews available. But I think because it was something we'd never done before, there was some apprehension or concern about actually implementing that advice. And I think that was really the reason why some ambulance services were more hesitant than others. But my view was really clear. This was a national emergency and we needed to act now to save as many lives as possible.
And in terms of staff that weren't students and increasing the capacity in call handling centres there, what were the barriers there?
Ambulance services recruiting sufficient staff, I just feel that some ambulance services really gripped it and thought we absolutely need to recruit more staff, advertise, go through the selection process, recruit and train. And other ambulance services, in my opinion, should have been more robust in the timescales that they applied in terms of being able to recruit all of those staff as quickly as we needed to.
And in either role for the AACE or as advisor, did you support those trusts in implementing those measures?
Absolutely. I kept giving advice to increase the capacity in the control rooms. The arrangements for recruiting 999 call handlers are in place. All ambulance services have those in place, and that's business as usual. But my advice was that we needed to substantially increase the number of 999 call handlers, because I was concerned that if the pressure was such that there was significant increase in 999 calls for ambulance services, That would place pressure on BT that answered the calls initially to determine whether you need police, fire or ambulance, and then connect the caller to the relevant emergency control room. That there could be members of the public that actually needed maybe fire or police that wouldn't be able to get through because BT would be so busy dealing with ambulance calls and not being able to connect them as quickly as necessary to the relevant ambulance control rooms. And I was doing everything I could to prevent the ambulance service and as part of our national critical infrastructure from being overwhelmed.
And you provided a checklist, I think, didn't you, for trusts to fill out for their surge preparation. Were they monitored for compliance?
That wasn't the purpose of the checklist. The checklist was to identify the areas where I felt ambulance services could focus their energy, where I believe this would give them the greatest benefit and the greatest impact to increase staff in the control rooms and ambulance crews. And then I followed up with specific advice to each individual ambulance service based on the information within their return.
And moving away from people to vehicles and fleet availability. In a survey on escalation of care that the inquiry commissioned, 45% of paramedics and 55% of GPs said that a barrier to escalating care was access to an ambulance. And as part of your role was about maximising fleet availability. So were you aware of these issues and was any support provided to increase the availability of the fleet?
Yes, it was. So there was a number of things. Firstly, again, I offered advice to say that we needed to increase the size of the fleet, which given ambulances are very specialist vehicles, that's not always easy to do, but I gave some specific advice about how that could be facilitated and indeed how we can reduce the downtime of the fleet to maximise the operational availability of the fleet that we did have. And that advice was ongoing as well, particularly for a couple of ambulance services. It did get into difficulty at various points during the waves of the pandemic.
And in terms of the use of non-emergency patient transport vehicles, particularly early on in the pandemic, where their work and their journey significantly reduced, was there any work done to try and utilise effectively their services and their vehicles and to coordinate that work?
Absolutely. A couple of points on that. Firstly, those PTS staff that volunteered to undertake additional training, we asked them to step forward, complete that additional training, and we used those staff on the lower acuity emergency calls and some urgent cases as well. And then for the PTS staff that were remaining, but that weren't required necessarily to do their normal PTS business as usual work, I asked that those crews paid particular attention to discharges patients from hospital so that we could really speed up the flow through the hospitals to avoid delays in the emergency department and delays of unloading ambulances outside of the emergency department.
Can you recall when that advice was given and when that work started?
Well, that was March 2020.
You have referred in your statement to the issues with staff absence in the ambulance service during the pandemic, and you've said how some 999 call handling centres were impacted by staff absence up to 30%. And indeed, NHS data shows that absence peaked actually later on in January 2020 at around 9%.
2020 or
2021, I beg your pardon. What action was taken at a national level to support trusts, not only to try and reduce the amount of staff sickness, but also to meet the demand when those staff sickness absence levels were high?
A couple of points. Firstly, national advice was issued to ambulance services to protect the workforce that we already had. So providing advice and the installation of plastic screens around the call handlers to protect them from the potential spread of any virus from colleagues sat in close proximity to those staff, but also regular wipe downs of their desks, using hand gel before and after they entered the control room, before and after they entered the building, and all of the IP&C arrangements that were set out for clinical areas were also applied in large part to non-clinical areas, which included the control room. So protecting the existing workforce was the first priority. I've already mentioned recruiting additional staff to deal with that capacity, but we also then put in place 2 filters with British Telecom that answer the 999 calls, one for information calls. Patients that actually didn't need an emergency ambulance but just wanted information in how to handle the COVID symptoms for themselves. And then secondly, later on, where there were delays for ambulances responding, patients would often ring back on the 999 system seeking an estimated time of arrival for the ambulance.
Mr. Marsh, I'm just going to stop you there because we're going to come on to those 2 call filters in more detail. But in terms of the staff absence in the call centres, it's right that there wasn't any national guidance for those non-clinical areas. So the AACE, in fact, produced working safely guidance, didn't they, that was updated throughout the pandemic for use in those areas?
That's correct, but there was initial business as usual arrangements for good IPC measures across all of our working areas, which included the control rooms, but more specific advice in response to the pandemic and rising absence levels was introduced later on by ACE, you're quite right.
And were you made aware of issues with implementing that advice on the ground? So whether it could actually be implemented?
Not in the control rooms from memory, no.
And what about other staff areas, staff rooms, breakout areas, those kind of areas?
Once the guidance had been issued, I'm confident no one ever drew to my attention that the guidance or the advice was not being followed, but I recognise there was a gap between business as usual, good hygiene amongst our work areas, and the more specific guidance that was issued for non-clinical areas in due course. And that was obviously why that additional guidance was issued.
Well, I think what Han's trying to get at is, for the previous witness, Mr. Tilley, I don't know if you had a chance to listen to his evidence.
Most of it I did, my lady.
The suggestion was that there were some trusts, certainly, where the guidance that you were giving, for good reason, wasn't being implemented.
Well,
They didn't come to your attention.
not to my attention. I am really sorry if that was the case, because the guidance was there for all of us to follow, to protect all of us.
You've accepted, Mr. Marsh, in your statement, there were times during the pandemic that demand did outstrip capacity in 999 call handling centres. Was enough done to prevent this happening early in the pandemic? Or early enough in the pandemic?
I don't believe it was.
My lady, before I move on to my next topic, I wonder if that might be a convenient time to have a break.
Certainly. I'm sorry about this, Mr. Marsh, but we take regular breaks for the sake of everybody. I shall return at 25 past.
All rise.
Hands.
Mr. Marsh, we're going to move on to a new topic of call handling and triage systems. First of all, I wanted to just establish what the systems are that are used in England. So we have 2 systems for emergency call handling. In fact, they're used across the UK, and that's NHS Pathways and AMPDS. And we're going to talk about the changes to the triage pathways that were introduced into 999 and 111 in response to the pandemic. It's right that you chaired the emergency call prioritisation advisory group advising NHS England on ambulance call prioritisation triage systems and clinical coding. Is that right?
Correct.
If we can have on the screen, please, INQ 30479-041. This is taken from your statement, and this sets out the initial changes that were made in mid-March 2020 to ambulance disposition codes within 999 and a new prioritisation pathway for COVID-19 callers contacting 999 with breathing difficulties. Could you briefly explain what this change meant in practice if I called 999 with COVID symptoms, firstly with breathing difficulties and then secondly without at this time?
When patients ring 999, once we've established whether the patient's breathing or not, we ask the caller, which may or may not be the patient, what the chief complaint that they're suffering with is. And if they were suffering with difficulty breathing or any particular problem with their breathing, then normally that patient would be taken through the difficulty breathing algorithm. But once the pandemic protocols were implemented, those patients would be taken through the pandemic protocol to establish or not whether those patients can be safely and appropriately dealt with without an ambulance being sent, or whether they need an ambulance to be sent, and therefore the speed of which and the category that would be applied to that particular patient.
When you say the pandemic protocol, are you talking about Protocol 36?
Yes, I am.
That wasn't introduced until the 3rd of April 2020. So looking at the changes that were made on the 12th of March 2020 in front of you, what was this pathway and how was this different?
These were two new disposition codes that were introduced to be able to identify, given the questions that were being asked of patients and the definitions of potential COVID at this point, if those patients potentially had COVID, then there was an opportunity, an option for the call handlers to assign one of those two codes to that particular patient.
What level of scrutiny did these changes undergo at this time?
It was the clinical coding group, which is made up of doctors, medical directors from ambulance services, and the clinical director within NHS England.
And between the introduction of this pathway in March and Protocol 36, which we'll come on to in April, was there any review of those disposition codes or any changes to them?
Not in that intervening period.
So these pathways remained in place with the disposition codes you've just described until Protocol 36 was introduced?
That's correct.
Moving on then to Protocol 36. My understanding, please correct me if I'm wrong, is that the intention of Protocol 36 was to ensure that call handling services were not so overwhelmed with calls about COVID-19 that they were prevented from triaging and responding to other incidents and to focus on those most in need.
Yes, it's designed that the ambulances aren't overwhelmed rather than the actual call handlers and the control rooms themselves.
And it's right that Protocol 36 was first proposed on the 23rd of March 2020 and implemented on the 3rd of April 2020 in all ambulance trusts. Is that right?
In England, correct.
In England. We know demand was increasing before that, and you've said in your statement that obtaining approval for pandemic triage code set changes or escalation levels often proved challenging due to the time it would take to get sign-off through NHS England, and therefore decisions were not always implemented quickly enough. Is this an example of when it wasn't implemented quickly enough?
No.
The current AAC chair has provided a statement to this inquiry, and he has referred to the trusts requesting permission to shorten call handling triage before Protocol 36 was introduced. And in fact, you wrote to ambulance trusts in England on the 7th of April, so a few days after Protocol 36 was introduced, with agreed principles to allow trusts to make changes to their call handling process. And AAC developed a set of codes that they could use alongside it. Why were these principles and this set of codes produced at this time when Protocol 36 had been introduced?
There's two separate issues here. We've talked about Protocol 36 and the escalation. This particular reference is in relation to a shortened training course for new 999 call handlers. The usual duration of training for new call handlers is about 5 weeks plus several weeks, maybe up to 2 months, where new staff, having completed their training, then work in the control room alongside existing experienced members of staff to gain their competence and to build their confidence before they take 999 calls on their own. And it had been drawn to my attention that a couple of ambulance services were looking to provide a shortened initial training course for new recruits, much less than the usual 5 weeks.
It's right, isn't it, that in fact they were looking to reduce it to 1 day from the 5 weeks?
So I believed in at least one service.
And what action did you take in response to that?
Well, as you referred, as soon as it was drawn to my attention, I sent an email to all ambulance service chief executives in England saying that I didn't support such a proposition. Clearly, it is a matter for individual ambulance services and their chief executives as to what training they provide, but I made my position very clear that I didn't think it was sensible. The training of 5 weeks is there for a reason, and that if ambulance services still believed it was the right thing to do, they needed to ensure that the training that they were going to provide, the shortened course, still met the requirements of the licence and the requirements of the regulator for that particular provider of the triage system. And then second, it was followed up with a letter which you just referred to, which again reaffirmed my position, but also did include some principles that if an ambulance service still believed it was the right thing or it was necessary for them to do, that they should at least apply and adhere to those principles that were set out by ACE.
And were any changes to the length of training monitored at a national level?
No, it was a matter for individual ambulance services.
Were you aware of any guidance or advice that was in place to support, for example, new call handlers around decision making on the type of assessments that they were offering to callers? For example, whether they were passed on to a clinical call handler for an assessment or remote assessment?
Are you referring to the new call handlers?
Both.
Yeah. Well, those arrangements exist business as usual. Call handlers are able to either transfer 999 callers or indeed, once they've closed the case, then place that case on the queue for paramedics and nurses to call those patients back where that's necessary. And control rooms generally have at least one paramedic that's available to provide in real time clinical advice whilst that call is in progress as well. That's business as usual.
Were you aware of instances where there wasn't the capacity to provide that clinical supervision to call handlers?
There would have been occasions where that option's not always available in all control rooms from time to time.
And in terms of Protocol 36, returning back to that, trusts that use NHS pathways as a system had to use paper workarounds with scripts. Is that right?
In the early stages, that is correct.
So it's right, isn't it, that they would be updated almost daily, sometimes multiple times a day, as the situation was developing in the early stages of the pandemic?
Correct.
And that would provide the script, the questions that the call handler should be asking the caller.
On the potential COVID algorithm, that is correct.
And was there any concern, or are you aware of there being any inconsistencies in that advice being followed, given that it was on a paper basis?
No. From time to time, previous to the pandemic, paper workarounds are introduced if something urgent comes up before the system can be updated. But as you quite rightly say, this was happening much more frequently given the change in information in relation to the initial wave of the pandemic.
I think in an investigation that was carried out by the Healthcare Safety Investigation Branch into 111 services, they in fact found that there was up to 35 different changes to the algorithm within 2020, whereas there would normally be 7 to 8 per year. Does that sound about right?
Yes, it does.
And so those would be in NHS pathways on paper?
Certainly the initial workarounds would be, but then they would be built into the system within a few weeks.
Moving on to the escalation and de-escalation of pandemic protocols and 999 call handling. You've set out in your statement that a tiered approach was taken to national changes, depending on the escalation level, but that it applied that level applied across England. Is that right?
That's correct.
If we could have up, please, INQ 4790041, and the top of the page. This is a table that's in your statement. Now we can see here the different levels from 0 to 3. These are just, for clarity, different to the REAP levels that we discussed this morning, aren't they?
Yes, they are.
Yes. And these were specific to COVID-19, is that right?
That's correct.
And it's correct that you had responsibility for deciding on the level at the time?
And making recommendations to NHS England for ratification, that's correct.
It's right that during the peak waves of COVID-19, Protocol 36 was implemented at level 1. Is that right? So when it was introduced in April, it was at level 1?
Correct.
But level 1 wasn't exceeded at all throughout the pandemic, was it?
Correct.
And in fact, we went back to level 0 quite a few times, didn't we?
That's also correct.
Why did we not go above level 1 in your view?
To move to level 2 and ultimately to level 3 would provide more codes for clinical assessment and potentially not initially sending ambulances. What I was trying to assess was the balance of risk across England as a whole to ensure that that balance was proportionate to those services which were under pressure and that clearly needed level 1, maybe an element of level 2, and the rest of the country that may not have been under the same amount of pressure, and trying to keep a consistent approach so that those ambulance services had availability to send ambulances still continued to do so. And in some ways, these Protocol 36 levels formalise the internal surge levels within ambulance services. And so I was clear that we needed to make sure that we didn't expose more risk by trying to address the particular challenges that might have existed in 1 or 2 ambulance services at any particular point in time.
So in practice, one ambulance service could be under severe pressure, but because as a whole the ambulance service in your view and recommendation was under moderate pressure, the whole of the ambulance services in England would be at level 2.
One.
One.
One, I beg your pardon, 1.
That's correct.
Thank you. If we could please have up INQ 3047 2375. And these are minutes of the ambulance expert group of the National Directors of Operations from the 4th of November 2020. Now, I accept that you weren't present at this meeting, but if we could look at the bottom of this document, please, where it's highlighted. And the escalation levels that we've just been looking at were discussed at this meeting. And we can see here that it says that the position was summarised as EMAS and NWAS. Now, they're 2 different ambulance services, aren't they?
Correct.
Were withdrawing their request to escalate following clarification. However, NASMED, and that's the National Ambulance Service Medical Executive Directors Group, isn't it?
Medical directors, yes.
Had not withdrawn their request. In essence, the process is not working as envisaged, and somebody confirmed that yes, and that's another ambulance service, is that right?
Correct.
Had withdrawn their request, and no further requests to escalate were received. What this is essentially showing is that 3 ambulance services had requested an escalation to a higher level, but their requests had been withdrawn. Is that right?
Correct.
But despite that, NASMED were of the view that there should still be consideration of an escalation to a higher level. In the second part of that box, there is a suggestion that the previous barrier to regional escalation had now been resolved, and that might open a possibility to NHS England reviewing, thank you, the process to introduce regional discussions on escalation rather than the national approach currently in place. Why was there no review at this point of whether, or was there a review at this point as to whether a regional approach to escalation would be beneficial?
There was a review, and I did consider the benefits and the disbenefits of moving from a national position to allowing some regional flexibility. But on balance, I still held the view, and so did other senior colleagues, that England remaining at one level consistently was still the right thing to do on balance.
It's right, isn't it, that in Wales they had adopted a more flexible approach where they could adapt based on the regional pressures at the time?
Yes, given that Wales is a devolved nation.
Moving further through this document to page 3, please. Yes, thank you. The major incident update in the North West Ambulance Service. Here, a major incident was declared, and the stack of holding calls was reduced from 520 to nearer 250, and it caused, in the Greater Manchester area, extensive delays, lost areas at ED. And then there was reference to a suspension of meal breaks and a request for a report. SOS is at the Secretary of State?
I believe so.
Thank you. Is this one of the consequences on a regional level of that decision not to allow for a regional approach to the levels?
No, not at all.
Can you explain why?
Of course. Individual ambulance services already have their specific surge plans. And whilst REAP is in place for a longer period of time, which we've discussed already, the individual surge plans are on the day, in the moment plans that deal with rising surge as increases in demand occur during the day, or maybe handover delays deteriorate during the day, or maybe inclement weather causes disruption for the ambulance service response. And so the individual ambulance service, and North West in this case, would still have had their specific surge plans that they would have applied in managing the demand and the pressures that they experience on that day, move into level 2 or even level 3 across the whole of England wouldn't have helped the North West on this particular day.
You provided the inquiry with a statement as Chief Executive of the West Midlands Ambulance Service, and you've referred in that statement to there being cells and regular meetings in response to COVID, which allowed the Trust to make informed, effective decisions about how to operationally respond, which were dynamic and were reactive to the changes in national guidance, resourcing and resource availability. Would you agree, therefore, that localised decision-making can allow for more dynamic and effective decisions and responses based on the situation on the ground, as happened in your trust?
Yes.
If we could have on the screen, please, INQ 00041061, please. This is a summary of a legal opinion you received in relation to changes to triage processes for COVID-19 on the 2nd of April 2020. So this is the day before Protocol 36 was implemented nationally in England. The question comments that it's not clear from the documentation as to how the needs of vulnerable groups have been taken into account. And then in the response below, it confirms that there has not been a formal impact assessment of the impact on vulnerable groups of the changes to triage before implementation, but it was going to remain under review. Was a review conducted at any point during the pandemic?
Not a formal review outside of the existing arrangements that are in place for the algorithms for all patients.
But Protocol 36 was introduced specifically for COVID-19, is that right?
It is, but the basis upon which the algorithms work are based on the clinical presentations for patients, and therefore the code and the category that follows from that.
Were you aware of Protocol 36 having an impact on vulnerable groups during the triage process?
Not any more than would have normally have been the case.
I want to turn now to the practical impact of Protocol 36 in a real-life example, so that we can put it into some context, and that can be seen in a report produced by the Emergency Call Prioritization Group that you chaired the 23rd of March 2020. So it's INQ 000281180. Thank you. And it's the box in the middle here. Essentially, what we have here is an example of what would happen under Protocol 36. So in order to demonstrate the comparable triage outcomes from the two systems, the clinical scenarios describe the change in management for a patient with low acuity symptoms and a patient requiring an emergency response. So dealing first with the low acuity, a 30-year-old who has chest pain and coronavirus symptoms will be assessed based on the symptoms and managed in a similar way as the triage levels escalate. Patients who are assigned a Category 5 response, priority at triage level 1 will be signposted to home management by call handlers at triage level 3. And that disposition would be the same in both the systems we've discussed under the pandemic protocols. And then in terms of the more serious emergency response, a patient who has severe breathing difficulties, classified as fighting for breath or ineffective breathing, will be allocated a Category 2 response across each of the escalating triage levels. A triage 2 response would be slower in terms of the ambulance arriving at the scene than a category 1 response. Is that right?
That's correct.
And that's the same in both of those examples. Is that right?
Well, in the first example, the patient would have been potentially assigned category 5.
And that would be a category 5 response under the pandemic protocol would be to have stay-at-home management advice.
Category 5 is for a clinical assessment ringback.
Thank you. Did that change apply to the triaging of callers who did not report COVID-19 symptoms?
There were some codes that were not on the Protocol 36 or the pandemic algorithm that were allocated a lower category response priority in levels 2 and in levels 3 if they had been implemented.
And it's right, isn't it, that in August 2020, the Emergency Call Prioritisation Group conducted a review of Protocol 36 specifically in regard to ineffective breathing and recommended that a Category 1 response should be received as opposed to Category 2. Is that right?
That's correct. That was a new code for ineffective breathing that was applied to the pandemic protocol at Category 2. And when we conducted that review in August, we decided that that code should receive a Category 1 response.
And were there any instances that had led to that decision being made in August?
It was just a review of those codes and the application of those codes. And as part of that review, it was determined that that code would be better suited to a Category 1 response. And so, therefore, it was changed.
Thank you. I want to look now at the meeting minutes from the National Ambulance Service Medical Directors meeting on the 23rd of April 2020, and this is INQ 30410-581. And here there was a discussion around the escalation levels of Protocol 36 or Card 36 as it's referred to here. There was a reference that it should be lowered to 0, but that it wasn't present at present. Wasn't possible at present, but they thought it should be considered if trusts were operating at good performance levels. If we could go down, please. Thank you, and just a little bit more. Thank you to several trusts. It was discussed at the meeting that several trusts had reported increases of patients found deceased when crews arrived, more serious illnesses in patients, patients waiting longer before calling 999, and patients were reluctant to go to hospital and needed to be convinced sometimes that the diagnosis related to other conditions and not COVID-19. And the North West Ambulance Service wanted to know how long you might need to stay on Card 36. I accept you weren't at that meeting, but were you aware of issues such as those described here, and did they continue throughout the pandemic?
So I was aware of the issues that are highlighted here, but I think there are two separate points being made here. Firstly, on level 1 of the pandemic protocol, actually, medical directors were reporting that many patients were getting a more appropriate, safe response rather than automatically just sending an emergency ambulance. And that was one of the considerations that led us to believe that remaining on level 1 was the right thing to do. In relation to the other point in this highlighted section, I do believe it was the case that some patients were delaying calling for help, and as a sad, terrible consequence of that, by the time the ambulance call was made and the ambulance arrived, those patients hadn't made it. And as we've gone on to see in this section, that even when the ambulance had arrived, some patients were also reluctant to be conveyed to hospital as well.
And you referred earlier on to the delays that there could be to the changing of triage codes. Was one of those examples a change to the script to include the loss of taste and smell in May 2020?
Not that I remember, no. I don't think there was a delay.
In the Healthcare Safety Investigation Branch report into 111 services, they found that there was in fact a delay of 4 days in which the script was not updated. So anybody calling in that period would not have been told it was a symptom. So you weren't aware of that?
No, not at the time.
Is that the kind of example of where the processes that were required to change the scripts impacted on the callers?
I don't believe so, because whilst that's an important factor in recognising whether the patient may or may not be suffering COVID, it wouldn't have influenced in any way the code that was allocated to the patient once they had been taken through the algorithm.
Moving on then to the demands on 999. There was a significant increase in 999 call answering time in England in March and April 2020, with an average 49 seconds compared to an average of 10 seconds before the pandemic. One of NAC's role was to monitor performance and report data. How did you respond to escalate those issues, and what did you do in response? What response did you receive to those issues?
So we were monitoring 999 call answering on a very regular basis throughout the day, every day, and receiving reports from British Telecom as to the number of over 2-minute delays on a daily basis in each ambulance service. And I asked the colleagues within ACE to develop some arrangements whereby they could provide support, advice and mutual aid to those ambulance services that were under pressure by strengthening the buddy arrangements which we already had in place, and to see what further steps we could take to provide mutual aid to those 999 ambulance services that were under pressure, and at the same time to ensure that the technical links were in place, that once a 999 call had been answered in an ambulance service for which the incident hadn't occurred, they could transfer the details of that case to the host ambulance service to enable them to respond.
And when was that introduced?
It was finally completed by October 2020, but most of those ambulance services already had the ability to transfer those cases, with the exception of London, and that was the one that took the most time to complete.
In your statement, you've discussed the issue of no-send scripts, and essentially they're used during times of significant pressure, for example, asking the call handler to make their own way to hospital as part of individual trust surge plans. So there's no national agreed script, is that right?
That's correct.
You've said that they were discussed at the emergency call prioritization group to standardise the scripts and set out the changes that were agreed nationally. Were those changes monitored for implementation to ensure that there was consistency across the trusts for the scripts that were used? Absolutely,
and that was the whole purpose of the pandemic protocol and moving through those levels. But no send was a generic term that was used, didn't automatically mean that all of those patients that resulted in that end disposition from that algorithm didn't get an ambulance. Some may have been advised to make their own way to hospital, but the majority of those patients actually were then sent for further clinical assessment before a decision was made whether they actually needed an ambulance or not. And some of them did, and then an ambulance was subsequently sent. Moving on then to NHS 111
during the pandemic. It's correct, isn't it, that the instruction from the Secretary of State was that NHS at 111 should remain the single point of contact for all inquiries for COVID-19.
Correct.
And were you a member of the NHS England 111 COVID-19 cell?
No.
Would it have been helpful if you had been a member of that cell to ensure consistency across 999 and 111 services?
I don't believe so.
We know that there was a dramatic increase in calls to 111 in March 2020, with over 3 million calls in that month, and over half of those were not answered. If we could please look at INQ 30348 this is a briefing note that was prepared for by Public Health England for a cabinet meeting the following day on the 26th of March. And the author states at the top there that the capacity whilst PHE has maintained high level of performance, this has been a difficult time for NHS 111, and we can see the performance of NHS 111 below. And they say that the capacity at NHS 111 had responded to around 40,000 calls, with slightly more weekends since the beginning of the incident, despite calls offered being regularly over 100,000 per day. So if anything, their ability to answer calls has dropped since mid-March. And in fact, if we look specifically at the 23rd of March, it is quite small at the bottom of the graph. You can see there that the NHS 111 call answers in 60 seconds is 10%, and the target was around 95% at that time. And then if we move down the page to page 3, please. And at the first paragraph, there'd been a request from NHS England and NHS 111 to PHE for additional 1,000 call handlers, which was achieved within 24 hours notice in order to support capacity of NHS 111 COVID response, separate from the PHE capacity. And then if we just go to the final page 4, please. And at the bottom. And paragraph 3.1, one of the issues that Public Health England draws attention to is that capacity issues at the end of March 2020 in NHS 111 remain. There'd been no attempt to augment the core capacity, and recruitment at the beginning of the incident would now be providing additional core NHS 111 staff, but that hadn't happened. To your knowledge, why did NHS England not recruit call handlers before the 26th of March?
I honestly don't know. I wasn't involved in decision making with NHS England in relation to 111, I'm afraid.
And are you able to help us with the call filters that were introduced to NHS 111 in March 2020 in order to manage demand?
I'll try if there's a specific question, of course.
Okay. If we could please have up INQ 30320-204. And this is the Healthcare Safety Investigation Branch report that I've referred to into the changes to 111 Triage. And these changes suggest that they were requested at the request of the NHS England Central Ambulance Team, and it was only to be used by providers when advised by NHS England. And this is a further pathway update at the end of March with a COVID-19 level 4 switch, enabling an ambulance category 3 and category 4 dispositions reached by core NHS 111 health advisors using the COVID-19 algorithm to instead be directed to a clinician with a speak to clinician from our service immediately. So is it right that in this, when this switch would be turned on, those that were calling that would ordinarily have received a Category 3 or Category 4 ambulance response would now be actually called back by a clinician in the first instance?
Yes, to determine their clinical needs, that's correct.
And is it correct that you were part of that NHS England Central Ambulance team?
Yes, that's true, yes.
So were you involved in advising when this should be switched on or off?
Yes.
If we move to the next page, please. And 4.2.8, and then we can see here that there were further updates to the pathway we've just been looking at around pregnancy, vulnerability, and the symptoms. And depending upon those would depend on the disposition that they reached.
That's correct.
Thank you. And if we move down to 4.2.10, sorry. This is another update the following day. So this is the 31st of March. Here, the summary of the update was that those who were not breathless and identified as extremely vulnerable by the NHS will be triaged for persistent cough and fever, and those over 65 years of age will now receive a full breathlessness triage and will reach an appropriate disposition. Are you aware as to the clinical input and quality assurance that those updates underwent?
No.
And it's correct that the call handlers that would be dealing with these issues were not clinically qualified or trained, were they?
That's correct.
And a substantial amount of them, as we've just looked at from that note, would be new call handlers that had just been drafted in that would be dealing with these calls.
Some of them would have been, yes. Yes.
And do you know how long their training period and supervision was?
I believe it's the same, if not very similar, circa 5 weeks, plus a good number of weeks in the call centres, gaining their experience and competence.
During the pandemic, are you aware as to whether that period of training was reduced?
Not formally, but whether an individual provider or an individual ambulance service reduced it, then that may well have been the case. But I certainly wasn't made aware of any shortening of the experience time in the control rooms.
Do you accept that the result of these changes overall was that more people were advised to manage their symptoms at home to reduce the demand on 111 services?
That would have been the case where it was believed to have been safe and appropriate, yes.
Thank you. That document can come down. If we could please have up INQ 40/69487. This is an email between the Deputy CMO, the CMO, and Department of Health and Social Care on the 30th of May 2020, where they refer to NHS 111 wanting to remove COVID symptoms. And it reports that NerveTag were very uncomfortable and that we would lose an important early warning system for a resurgence, and a note from 111 had been requested. Were you aware or involved in discussions about NHS 111 no longer coding COVID-19 cases and the impact that could have?
Not at all.
Do you know who would have been involved in that decision?
I'm assuming it would be the NHS 111 Pathways team, but I couldn't be sure.
Thank you, that can come down. We've discussed a little bit about the alternative and additional helplines and assessment services that were set up during the pandemic, and indeed there were a number of them. Those being set up by NHS England were the COVID Response Service and the COVID Clinical Assessment Service. And then there was also the Public Health England helpline. Is that right?
That's my understanding.
And were you involved in setting those up, monitoring or deciding on when they would be switched on or off?
None of those at all.
NHS England was responsible for monitoring the COVID response service, so you didn't play any part in that.
That's correct. I played no part in it.
Moving on then to the NHS 111 First service, which you referred to. This was a booking system for NHS 111 online, NHS 111 and NHS online, 111 online, for emergency departments that was available to trusts by March 2021. To encourage access and to reduce pressures on A&E and NHS 111. Were you involved in the implementation of that?
No. But I was aware of it.
And in terms of future triage systems, you've recommended that there should be a single NHS 999 call prioritisation triage system. And in fact, the AACE made a similar finding following a review in July 2020. Are you aware as to whether anything was done in response to such findings at that time or since to implement that?
No. This has been an ongoing debate amongst ambulance services for many years, actually. And I do strongly believe that having one prioritisation system for 999 ambulance calls is the right thing to do.
Moving on to the topic of call filtering, please. It's right that you approved the switching on of a BT call filter on the 27th of March 2020 to refer patients calling 999 who required COVID advice to NHS 111 online if it wasn't life-threatening or they were not over 5 or above 70 years old. Is that right?
Under 5 and over 70, that's correct.
Yes. And on the 15th of April 2020, there was an update to that to change the 5 years old to 16 years old. Were you involved in that decision?
Yes.
Can you explain why that change was made?
That was advice that was given to us by some of the ambulance service medical directors and the NHS England clinical director.
And it's right that those call filters were switched on and off throughout the pandemic, is that right?
Correct.
And the second filter that you switched, that you advised on, is one that you referred to around duplicate callers asking for an ETA as to when their ambulance would arrive if they'd already requested it and they hadn't deteriorated. In the expert report from Professor Snook, she referred to research during the pandemic identifying that NHS 111 telephone triage may have underestimated the importance of those repeated callers as predictors of adverse outcomes. Is that something that you recognise, and is that something that was considered before the call filter was switched on?
Not at that point. That was knowledge that wasn't known to us at that time, but we did very clearly set out in the algorithm which was issued to BT for their use that if the patient had deteriorated or the condition had changed, then the call was to be connected to the ambulance control room. It was only those patients that felt comfortable that the condition hadn't deteriorated or changed in any way, that they were simply only asking for an ETA. It was those calls that were not connected to the ambulance control rooms.
Are you aware of any training that those call handlers were given on that distinction?
I'm not aware of any training, but the algorithm was very straightforward, a series of yes-no questions and answers. And of course, if there was any doubt, then we said to BT, please connect the caller to the control room.
Moving on to conveyance to hospital and decision support tools. It's right, isn't it, that NHS England developed clinical guidance for paramedics to aid decision-making on conveyance to hospital for adult patients in April 2020.
That's correct.
And in fact, that guidance was issued on the 10th of April 2020, but it was issued by mistake, essentially, because there'd been identification of potential impact on patient safety with the inclusion of the clinical frailty scale.
Correct.
And later that month, it was reissued without the clinical frailty scale, is that right?
That's my understanding, yes.
So there were 12 days when it was in use. Do you know if patient safety was monitored during that time?
To be honest, I've not found any evidence that ambulance services applied that guidance. It was posted on the website, as I understand it, but I actually don't think it was implemented in any ambulance service.
And it's right that there was no national guidance issued on conveyance after that until much later in the pandemic. Is that right?
Until much later, when the toolkit algorithms were published.
And as a result of that, were you aware that ambulance trusts were developing their own tools?
Yes, but again, some ambulance services will have had, or potentially would have had, some kind of conveyance advice or tools within their individual trusts. But overwhelmingly, the guidance for ambulance paramedics on conveyance of patients exists within the Joint Royal College's Ambulance Liaison Committee guidelines.
Were you aware of requests from those on the front line who were making those decisions for a national tool to support that decision making?
Not specifically, no.
Could we have up, please, INQ 304999523? And if we could go to page 34. This is the survey that the inquiry commissioned into escalation of care decision making. And if we look at the fourth quotation down, this is a quotation from a paramedic who said that one example of frontline staff being left to make very difficult decisions on managing critically unwell patients was not being able to ventilate a patient unless we're in level 3 PPE. Sorry, it actually should be the top one. Sorry, that's my fault. The first one, the harm from inability to escalate care. Thank you. So it's very difficult and upsetting to leave some sick patients at home due to tightening of criteria for conveyance to A&E. Some of these patients would have deteriorated and died. I understand why it had to happen, but it went against my paramedic values. Do you agree that a national tool early in the pandemic would have assisted those on the front line that were making these kind of decisions?
Possibly.
And it was January 2021 when a decision support tool was issued, but use of it in ambulance services in England was discretionary. Is that right?
Correct.
What led to the tool being developed at that time?
Well, I wasn't involved in the development of the tool, but my understanding is that it was in an attempt to standardise advice over and above that which already exists within the Joint Royal College's guidelines, so that paramedics had a clearer algorithm to follow for patients based on a series of observations to help them decide which patients needed to be conveyed to hospital and which of those patients could safely be left at home.
And did you receive any feedback as to the benefits of that advice after it had been issued?
No.
Were you made aware of any guidance or reasonable adjustments that were made to allow for patients with additional needs to be accompanied in an ambulance during conveyance to hospital?
The guidelines that were issued were for patients that had no requirement for someone to accompany them, that they should be conveyed alone, but for those patients that were vulnerable or children, etc., then should have an appropriate responsible adult conveyed with that patient.
And were you made aware of any issues with that guidance being followed?
Not other than it was enormously distressing for patients and their relatives.
I want to move on now to infection prevention and control. It's right, isn't it, that national guidance is invariably based on hospital settings and not always suitable for the ambulance setting, and that was the case pre-pandemic.
That's correct.
So when it came to the pandemic, it had to be updated multiple times, which you said took some time to arrange. Is that right?
Sometimes, yes.
And part of ACE's role was to review that guidance and to make recommendations to NHS England. Is that right?
Yes.
And I think you've said in your statement that they were always accepted.
Yes.
If we could look, please, at INQ 302261616. This is feedback from a survey of the workforce at the West Midlands Ambulance Service, where your trust, following wave 2. And if we could look at box 2, some of the feedback received from those in your trust was that the trust had taken the approach that one PPE solution fits all. And they were saying that this isn't always the case, and it's not always possible. So staff have to balance risk benefits and often fly intubated patients whilst in level 2 PPE. We've asked for a specialist solution, but been told the same WAMAS party line. I think going forward there has to be acceptance that specialist teams may require specialist PPE. Is that one solution fits all approach something that you were aware of during the pandemic?
Certainly in my service, we were very clear that before the pandemic we had already procured the respiratory hoods because we recognised the enormous challenges of fit testing, etc., with FFP3 masks, and so we moved to the respiratory hoods. And of course, during the pandemic, I was very clear that we were going to do everything necessary to protect our staff and therefore to protect the emergency service. And actually, in the early stages of the pandemic, potential COVID patients, and certainly patients for which an AGP was being undertaken that would have required level 3, shouldn't have been conveyed in the aircraft anyway, because at that point we weren't able to adequately decontaminate the aircraft having conveyed such a patient. So those patients would have been conveyed by land, as they would if the aircraft's not flying, and indeed at night when the aircraft didn't fly.
Thank you. Did you seek to raise those concerns at a national level in those roles that you held around the guidance and PPE and the solutions?
Well, more generally, I was aware that staff were concerned about the levels of PPE that they were being advised to wear, and I absolutely raised their concerns with senior colleagues within NHS England, yes.
And we'll come on to that in a bit more detail. Throughout the pandemic, the hierarchy of controls was promoted by public health bodies and AACE. We heard from the College of Paramedics last week that they didn't think it was suitable for the sector. And indeed, they raised those concerns throughout the pandemic. Do you agree that it was not appropriate for the sector, and did you take any action to escalate those concerns?
Well, I actually think that applying the hierarchy of control is the right thing to do. The principles set out in the hierarchy, for example, eliminating the risk where that's possible. We increased hear and treat rates through the protocol 36 level 1 we've already discussed, by ventilating the areas best you can, by regular wiping down of surfaces, etc., I think is the right thing to do. But I absolutely recognise the enormous anxiety that frontline staff were experiencing in dealing with the pandemic.
The UK IPC cell agreed on the 6th of March 2020 that PPE for ambulance guidance would be quote, downgraded. And it was David Cunningham on behalf of the AACE that attended on behalf of the sector. During a later meeting in that month, it was confirmed that ambulance trusts were not consulted on ambulance PPE guidance. At that time, you were chair of the AACE. So how regularly did you correspond with Mr. Cunningham and discuss the information coming out of the cell with him?
Not at all. That was dealt with by the expert groups of the IP&C with NHS England, the IPC cell, and Public Health England. It falls outside of my experience and expertise, so there would have been no value in me regularly meeting with the experts.
But you received correspondence from, for example, Unison and the GMB Union and the College of Paramedics about the issues that they were having with the recommended level of PPE and RPE on the front line. Did you seek to raise those or bring those to Mr. Cunningham's attention in order for them to be raised at the UK IPC cell?
Yes, he was aware of the concerns. I raised it with colleagues that were in in ACE, and of course the colleagues that were part of the Ambulance Policy Advisory and Assurance Group that was established as well.
And what was the response?
That we should continue to follow the guidance from the experts of Public Health England and the NHS England IPC cell.
If I could bring you forward a bit more in time now to the end of 2020, the start of 2021, where we start to see an increase in the handover delays. So if we could look, please, at a graph in your statement, it's INQ 3047900041, and the national handover delays are set out there at the top. It's correct that the target is 15 minutes, isn't it?
Correct.
And we can see here that that their delays are increasing in December 2020 and January 2021, and coming up to, well, certainly over 30,000
Yes.
hours lost in those 2 months. And then from April 2021 onwards, we can see a significant deterioration in the hours lost, can't we?
Correct.
And put very simply, that meant that patients and crew were spending longer in the back of an ambulance cab than they would have been had there not been the delays. Is that right?
Absolutely right.
And I think it's right to say that sometimes up to 12 hours in December 2021, and the longest delay in that month was in fact 20 hours.
Correct.
The inquiry heard from the College of Paramedics last week that as delays increased at the end of 2020, they were advocating for a change in the IPC guidance for staff to have flexibility to conduct a dynamic risk assessment on their PPE levels. Did you share those concerns at that time as well, that paramedics essentially should be given that flexibility?
They already had it. Even from the very start of the publication of the guidance for ambulance staff, they already had the ability, having undertaken what we called the dynamic risk assessment. It was simple, a case of assessing the risk that you believed you were being confronted with, and if the level of PPE, the minimum level of PPE, whether it was level 2 or indeed level 3, if you didn't think that risk that you were being confronted with was being sufficiently mitigated, our staff had the ability to upgrade some or all of their PPE in order that they felt safe. And that was no different when we got into these dreadful handover delays in the winter.
But
It's
does
right.
that depend, sorry to interrupt, but does that depend on whether they could upgrade, whether the equipment was on the ambulance?
I absolutely accept that that is also down to availability. But the point I was making was they already did have the ability to upgrade where that equipment was available, and it should have been made available.
It's right, though, isn't it, that there was no guidance on how to actually conduct that dynamic risk assessment until 2022?
There may not have been specific written guidance, but as staff are well-trained, professional colleagues right across the country, that by their own admission, and I fully understand that, were feeling enormously vulnerable, and they felt that the PPE that they were being advised to wear was inadequate. So by definition, if they'd established that they believed the PPE was inadequate, they'd already undertaken a dynamic risk assessment, even if it was just subconsciously, and therefore they could have and were able to, subject to the equipment being available, being able to upgrade any item or all of the items of PPE.
Ms Nichols from the College of Paramedics told the inquiry that it was impossible to carry out a risk assessment about COVID because you didn't know what you were going to, and staff would often be working in closed spaces with no windows, and she wasn't aware of any training for COVID risk assessments specifically. Do you think that would have been helpful to have had training or guidance earlier than 2022?
I think it would have been very helpful if we'd used language narrative that was much more straightforward for our crews, using terminology like a dynamic risk assessment and hierarchy of control, when actually we were saying, if you don't feel safe, upgrade your PPE, would have been much more straightforward. I entirely accept that.
Doesn't seem to be an NHS thing, speaking in plain
No,
English.
it's a challenge. We need to get better at that, my lady.
The outcome of the College of Paramedics raising those concerns and the UK IPC cell considering them was that there was no change to the national PPE guidance or any changes for the ambulance setting at that time. Is that right?
That's my understanding. That's correct.
And there were a set of suggestions made as to how the risks could be mitigated. So if we could have on the screen, please, INQ 30 472 354. Thank you. And just down to the bullet points, if I can just summarise these, essentially they advise that patients should wear a surgical mask at all times where possible, minimise people accompanying the patient, avoid sitting face-to-face, maintain ventilation systems, rotate clinicians regularly, and decontaminate more frequently. Those suggestions appeared a bit later on in statements by the AACE. Ms Nichols told us about how she was disappointed by this response. Mr Marsh, were these suggestions practical in the ambulance setting, for example, the back of a cab, in the middle of winter during these handover delays?
Well, so I think a couple of things. Firstly, I absolutely recognise the stress and the anxiety our staff were under. I share that absolutely. But I also think that taking a sensible approach as best we could within the circumstances ambulance crews work of, as best you can, ventilating the ambulance, the patient wearing a mask where that wouldn't undermine their clinical treatment, and wiping down are good measures. Most of those, with the exception of the patients wearing a face mask, most of those measures would have been taken as business as usual anyway. And I accept, in the winter, you wouldn't want to leave both of the back doors wide open for all of the time, but you could leave a door slightly ajar because we are into a balance of risk, trying to mitigate the risk of any potential transmission, but also protecting the patient as well.
Another matter that was discussed on the same topic of the back of ambulance cabs is that of ventilation. In fact, it was discussed at the UK IPC cell in June 2021, where it was recorded that Public Health England had raised concerns about poor ambulance ventilation. But it wasn't taken any further as events had moved on and the scenario was no longer relevant. Was the lack of ventilation and extraction in ambulance vehicles and the unique environment of the back of an ambulance cab given enough attention in guidance during the pandemic?
I believe it was. That's not to say that we could have communicated to our staff in a much more straightforward way. But as I understand it, advice was given to crews to set the ventilation system to extract in the back of the vehicle. That the changes per hour, the minimum standard in the changes per hour in the back of an ambulance is 20 per hour. In hospital rooms, it's about 12. And in the ambulance, the specification of the ambulances in my service, it's 20 times per hour. And of course, there was also the option where appropriate to leave one of the doors ajar as well to be able to provide fresh air ventilation into the ambulance as well.
The delays that we were looking at continued, as we saw in that graph. And in an AACE report, they concluded that 12,000 patients by the end of 2021 could have experienced severe harm, including patients with COVID who needed continuous oxygen therapy. Was enough done at a national level to prevent these delays increasing? And what more could have been done?
Well, I raised my deep concerns in relation to ambulance crews being unable to hand over their patients promptly, almost on a daily basis. There were various meetings and national meetings on the pressures across ambulance services every day. And everyone was aware, we mentioned earlier, the National Ambulance Coordination Centre live dashboard that included long delays. There were daily reports setting out the numbers of lost hours in each ambulance service, the longest delays at each of the most challenged hospitals across the country. So we were all aware, everybody was aware of the enormous pressures. And despite everyone's best efforts, unfortunately, those delays in handing over patients continued.
Moving on to non-emergency patient transport services, were you aware of concerns around the issues with social distancing when conveying multiple patients to hospital in those vehicles?
Yes, and that's why national guidance was issued, yes.
It wasn't issued until September 2020, though, was it?
I think it was issued, there was clarification and changes in September, but the initial guidance was published much sooner, I think March 2020.
And were you aware and did you help with resolving issues around access to the national PPE supply for those providing non-emergency patient transport services that were not part of the NHS?
I wasn't aware that there were challenges, only much more recently that some non-NHS PTS providers experienced difficulty, which is a great shame because frankly, had I been made aware at the time, I would have definitely intervened and resolved the challenges that they were experiencing.
Dealing briefly with aerosol generating procedures, and I really do want to deal with this briefly, but it's right, isn't it, that there were contrary positions adopted by the different bodies, including Public Health England, NAACE and the Royal College of, the Resuscitation Council UK and College of Paramedics, as to whether or not CPR and intubation were an AGP. Were you aware of those contrary positions?
Yes,
at the time?
I think, if I may, I think it was more about whether cardiac massage constituted an AGP rather than any of the other procedures. But yes, I was aware that there were conflicting opinions.
And what role did you play in trying to assist perhaps those that came to you with concerns or anxieties around those different positions?
Two things. Firstly, to ensure that the experts were aware of the concerns that were being raised by ambulance staff and by paramedics, so that everyone was very clear. And then secondly, that my view was that we should still continue to follow the advice of the experts. They had access to all of the experience, the expertise, the scientific data, and therefore we should follow their advice.
And if we could please have up INQ 304995523, please. And again, this is a quotation from the survey that was commissioned by the Inquiry into Escalation of Care, and this is the quotation I took you to earlier. So the example of frontline staff being left to make very difficult decisions and managing critically unwell patients was not being able to ventilate a patient unless we were in level 3 PPE. Ambulance staff were therefore forced to not intervene when they had the skills and equipment to hand and watch people die. Arguably, this was implemented to protect ambulance staff from contracting COVID, but still an ethically challenging time. Were you aware of those concerns at the time?
Yes, I was.
And did you do anything to try and escalate or deal with those matters?
Well, as I mentioned, I raised the concerns of frontline staff with senior colleagues. But I think the point that's being made here is that the moral injury, the moral harm that was being caused to frontline staff, because they knew, we all know, that time is of the essence for those patients that are critically ill, that we need to move forward as quickly as we can. I think the point, if I'm understanding it correctly, is being made here that staff felt that whilst they were donning that level 3 PPE, we were losing time to be able to help that patient.
And did you consider whether there might be anything that could help reducing that time to don that level of PPE, for example, whilst they were travelling to the scene?
I honestly don't believe that would have been safe for the crew to have done so. You've
touched briefly on shortages of PPE. in the non-emergency ambulance vehicles. What action did you take to ensure that the ambulance sector was prioritised for access to and resupply of PPE and RPE?
I made it very clear with national colleagues that given the unique circumstances that ambulance crews work in, i.e. no access to running water, so it was much more difficult for ambulance crews to be able to wash their hands and their equipment, that appropriate PPE should be prioritised to the ambulance sector, but also the types of PPE as well. So, for example, the aprons.
And what was the response to those requests you received?
They were accepted. The situation was understood. The request was accepted. So, for example, the slightly thicker aprons were attempted to be prioritised to the ambulance service, but actually that ambition to ensure that those thicker aprons were sent to ambulance services didn't always happen on the ground, and I suspect that may just be down to the logistics, the huge logistical operation that was having to be put in place to get that PPE, the right PPE, to the right NHS sector.
And you've referred earlier in your evidence to the use of the power respiratory hoods in your trust. Did you take any action on a more national level to encourage the use or availability of that type of RPE in other trusts?
Certainly the use, not the availability. That was clearly outside of my control, unfortunately. But every ambulance service was aware that at least 2 services had already procured the respiratory hoods before the pandemic, in fact, earlier in 2019. And other ambulance services during the pandemic, when they absolutely as well recognised the challenges of fit testing and the different types of FFP3 masks that were being delivered and therefore having to repeat the fit testing, etc. Several other ambulance services attempted to move over onto respiratory hoods as well.
And were you aware of fit testing issues?
Yes, that was one of the main reasons we moved to respiratory hoods in 2019.
And on a national level, not just on your trust, were you aware of that during the pandemic?
Yes.
And were you aware, you've talked about those hoods becoming available, well, advising that they should be looked at and considered, but not necessarily available. So were you aware of there being issues with alternative PPE being made available if fit tests were failed?
There was no national, so far as I'm aware, there was no national alternative to FFP3s. Respiratory hoods, to the best of my knowledge, weren't being made available through the NHS push stock.
I think, in fact, it's one of your recommendations that should be considered. Is that right?
Absolutely, my lady, yes.
Dealing with the issue of COVID-19 testing for ambulance workers, can you explain what your involvement in that was, please?
Yes, as soon as testing was being made available, I made it very clear nationally that I believed that ambulance staff, critical ambulance staff, should be including early testing. And by critical, I meant frontline crews, paramedics, but also the control room staff as well. I truly believe those staff needed to be included in the early rollout of testing, and that advice was accepted as well.
You've said in your statement on the topic of risk assessments for staff that you were aware that some ethnic minority staff felt that risk assessments had been tokenistic and failed to lead to sustained change or action. Did you take any action in response to such concerns, or did you have those concerns at the time? And if so, did you make any response to them?
I wasn't aware of specific concerns absolutely at the time, which was around May 2020. But certainly I was doing everything I could in my own trust to make sure that we firstly protected our vulnerable staff, particularly our BME staff, and equally importantly, that they understood that we were doing everything we could to protect them as well.
Do you think there should have been a national risk assessment tool for the ambulance sector specifically?
I think a standard risk assessment would have been helpful. Each individual ambulance service developed their own risk assessment, but I think a standard national risk assessment would have been helpful, yes.
And were you aware in your national roles of issues implementing or following risk assessments in other trusts?
No.
You've said in your statement that your belief is that IPC guidance was sufficiently clear for the ambulance sector setting, and there were clear definitions for what procedures constituted an AGP. Based on the evidence you've heard, do you accept that there were those some on the ground implementing that guidance who did not agree with that assessment of it?
I think if you don't mind me saying, if the question is, do I believe the guidance was clear? I do believe the guidance was clear. If the question is slightly nuanced insofar that did everyone agree with the guidance, I think that's slightly different. And I think there were other things at play as well.
Would you accept that others may have formed the contrary view that it was clear?
Yes.
My lady, I have just a couple more topics, but I wondered if that might be a convenient place to break.
How long do you think your couple of topics will take?
No longer than 15 to 20 minutes, my lady.
Oh, another 15 to 20 minutes.
15
Right.
minutes, yes.
Are you all right to come back this afternoon, Mr. Marsh?
Yes, my lady.
Very well. I shall return at 1:45.
All rise.